So if I remember where we left off, oh, I gotta stop sharing. Okay. Share. Da. Want sound for this one. So where I believe we left off is we just kind of left off at an introduction to autism, where really what I wanted to explain is kind of the reasons that we have seen such a exponential increase in the diagnosis, and part of it is due to awareness, we believe, and the other part is due to our changing definition of what autism is. As I mentioned last Thursday, if you looked in the night before the 90s when we changed additions for the um, um, DSM, many children who had autism before then were actually diagnosed with childhood schizophrenia. And then when we get to the 2010s, there were similar disorders such as Asperger's that had set similar symptomology as milder versions of autism. Those were also absorbed into the diagnosis of autism. And then with the increased awareness programs surrounding the disorder, it has increased the acceptability and the diagnosis of the disorder as it's increased. So it's been kind of twofold. But kind of want to play a video that really kind of simplifies what autism is. So I want to play this video for you all, and then we will go from there with some very specific etiologies and symptomology.
Hey there, welcome to Life Noggin. A lot of people talk about autism, but not everyone understands what it is. Autism spectrum disorder, or ASD, affects how people communicate with and relate to others. This isn't the same as being shy or not knowing what to say. Most people with autism don't understand some of the basic social conventions that others take for granted. They might have trouble making eye contact, holding a conversation, or recognizing gestures. And over 1/3 of people with ASD are nonverbal, meaning they don't use speech. Along with communication issues, people with autism often like to follow certain patterns or repeated behaviors. Many have a sensitivity to bright light or loud noises, and others have physical problems like trouble walking or picking up small objects. Some have intellectual disabilities, but about half have average or above average IQs. It's also common for people with autism to have a great long-term memory for certain details, and many excel in math, science, music, or art. With such a wide variety of symptoms, no two people with ASD are alike. The behaviors vary so much that they used to be classified as different disorders. One was Asperger's syndrome, where people obsess over particular topics, miss nonverbal social cues, and may not understand appropriate social behavior. In 2013, scientists realized that the boundary between Asperger's syndrome and some of the other disorders was fuzzy, so they decided to put them all under one name. This made it easier to diagnose autism, which is important. The younger someone is diagnosed, the earlier they can get help. In fact, many children who have autism will show signs by just 2 years old, including not responding to their name, avoiding eye contact, and flapping their hands or rocking repeatedly. Even though there is no cure for ASD, therapy and medication can help people adjust. Scientists are also doing clinical trials to find other solutions. They've learned that 1 out of every 68 children in the US has the disorder, but they still aren't sure what causes it. Autism is over 4 times more common in boys than girls, and most scientists think genes play a role because it often runs in families. Some people with ASD have abnormal chromosomes, but this can't be the whole story. There are people with the same gene changes who don't have autism. Other possible causes include having older parents, being exposed to high levels of testosterone in the womb, and having complications during pregnancy or birth. It may even have something to do with gut bacteria, since many autistic people have gastrointestinal issues. But most likely it's a combination of many factors. The one thing scientists know for sure is that vaccines do not cause autism. No matter why it happens, ASD is being diagnosed at a higher rate every year. This doesn't mean it's becoming more common. It just means more people are aware of the condition and getting diagnosed early. And awareness is crucial. The more we learn about autism, the more we can understand and relate to those who have it. It's important to note that people with ASD deserve the same respect, fairness, and chances that people without ASD receive. This will help people with ASD adapt and grow in our communities. We've put some resources in the description if you would like to learn more about ASD and figure out what you can do to help. Is there another disorder or any other topic you would like us to talk about? Let us. Hey there.
Okay, so that just gives a kind of a quick illustration of what autism is, and I'd like to just emphasize a few things that were mentioned in there. One is that it is primarily a social disorder, and secondarily, a restrictive behavior disorder. The other thing that I note, because it's a wonderful example, is that autism is one of the first disorders that has been put on what's called the spectrum. If you look at the DSM-5, most disorders are put on a spectrum instead of having a single diagnosis. So you have from mild to severe forms of autism. And at each level on the spectrum, it kind of tells you what level of care is necessary for that individual. Okay. So let's go over some of the symptomologies that are often looked at when it comes to autism. So again, we have this persistent deficiency, so over time, in social communication and social interactions, and again, paying attention in multiple contexts. Okay. Um, uh, Again, coming from the field that I came in before I went into academics, it is not uncommon, for example, for a child who has been severely abused in a given context to have social communication and social interaction deficits in that context, or in whether it be the home, a school, a church. That what sets individual with autism aside is a lot of times there is no history of abuse, but also it occurs in every context that the child is in. Okay. So let's take a look at a few of these social communication and interaction issues. So deficits in social emotional reciprocity, ranging, for example, from abnormal social approaches to failure normal back and forth conversation, reduced sharing and interest in emotions, a failure to initiate or respond to social interactions is probably one of the more common symptoms when dealing with children with autism, or interacting with, I shouldn't say dealing, interacting with children with autism. You can also see deficits in nonverbal communication. So either they interact inappropriately, or they have a very flat reaction to individual social interactions. Okay. Deficits in developing and maintaining and understanding relationships, ranging from, for example, relationships with mom and dad to relationships with their peers, again, in these various social contexts. And this is also marked, especially in that early childhood period, about doing that shared imaginative play and making friends to the absence of interest in peers. That age group, remember, between 3 and 5, where imaginative and role play becomes really important for children to develop those interactive skills. We often see these difficulties in those contexts, in those situations. Okay. Now, those social interaction issues then give way to these restrictive pattern of behaviors. Okay. In the app, if these behaviors are absent from the social interaction issues, the child doesn't have autism. They usually have some type of neurological or intellectual developmental disability. So it's important to recognize that one thing that has to be ruled out, and we'll get to this in just a minute, are other intellectual development disabilities. It has to begin with the social interaction aspect. Okay. But those inability to deal with the world lead to restricted, repetitive patterns, interests, and activities. And it can be manifested in at least two of the following ways. So at least two of these need to be present according to the DSM. Is you either have stereotyped or repetitive motor movement, okay? Um, where things need to become very methodical and motorized, insist on sameness, and this is probably one of the most common symptomologies, secondary symptomologies that we see, is insistence on sameness and inflexibility, uh, uh, inflexible to adherence to a routine. They need to have everything ritualized. Okay. Highly restricted or fixated interests are abnormal in intensity and focus. Okay. Hyper or hypoactivity in sensory input, or unusual interest in sensory aspects of the environment. So, either a hypo or hyper reaction to things like pain and temperature, or sound levels, excessive smelling or touching of objects of visual fascination. So it can either be either over sought, or it's an avoidant behavior. Okay. So these are some of then kind of the rule outs and restrictions on the symptoms must be present early in developmental period. Um, and symptoms cause clinically significant impairment to the social, occupation, and other important current functions. And this is what I was mentioning earlier, before, especially because of those, if there's the absence of the social interaction symptoms, but there's still that category two of those repetitive rigidity ones. We need to make sure that we rule out things like intellectual disability, such as intellectual developmental disorder, global developmental delay. Intellectual disability and autism spectrum can frequently co-occur. So, as that video mentioned, about 50% of children with autism also are score lower in intellectual ability. But still, in order for to assure those social communication should still also be below that expected general developmental level. Okay. Again, I just want to focus on the idea that autism is primarily a social disorder, and then the reactive behaviors are a way to deal with that social interaction that they have with their world. Okay. Right. Now, this just kind of explains the spectrum. Okay. And so we go from level one, where there's required support. But the child is still able to function on their own. They have some social abilities, but they have difficulty still with things like uh, being comfortable for a long period of time, socializing, those types of things. They have difficulties understanding why people react the way they do. And then we go to level three, where the child is has severe deficits in both these are the children that tend to be nonverbal communicators. They tend to have severe deficits in social interaction. This is the child, the infant that is born that won't allow mom or dad to hold them, those kinds of things, and it creates great distress. And changing patterns of behavior is very difficult for these children. So it's just the severity, this is kind of that spectrum from requiring little support to a little bit more, to where that you're almost there for the need to be there for the child 24/7 in care situations. Okay, so this is what's meant by spectrum. Now, I do just want to mention when it does come to autism, and the same argument is being made for disorders like Down syndrome and for ADHD, which we will get to in a minute, that should we really be seeing these children as having a disorder? Is an autistic child disordered in nature? Okay. And this is where we have something known as the neurodivergent movement, which I'd like to explain for just a minute because it is a movement that is trying to redefine what we mean by a child with autism or ADHD or Down syndrome. This one is very specific to autism. So the neurodivergent movement views autism not as a disorder to be fixed, and that's the difference, but a natural variation in human neurology, similar to the difference between things like learning style and personality. Okay. They see these individuals as having a different way of viewing the world. Okay. It emphasizes that autistic people have strengths and abilities, such as the ability to deeply focus, do pattern recognitions. They are deeply, deeply honest and creative and should be recognized alongside their challenges. Okay. And this movement advocates for acceptance over assimilation, meaning society should adapt environments, expectations, and support rather than forcing autistic children to conform to what are known as neurotypical individuals. Okay. The challenges the medical model of autism by promoting a rights-based approach instead of focusing on a that focuses on autonomy, dignity, accessibility, and avoids stigmatizing and pathological language. Okay, autistic self-advocates play a central role. Nothing about us without us, and it's really a movement, especially within the autism community. And so this is something to think about. The neurodivergent movement started in the early 2000s. It really has become a something to be reckoned with. If you go on YouTube, you can see all kinds of different talks and speeches by people who promote the neurodivergent movement. But it's something to think about because when we go look back in history, um, and this is one of the main neurodivergent arguments, is that when we look at individuals in the past, they, and you look at the diagnostic criteria for autism and all of those things, a lot of great individuals, if we go to Da Vinci, to um, Lincoln, to uh, all of many of the artists and whatnot that has created our 20th century, they all have symptomologies, if you read their biographies or autobiographies, symptomology of autism or ADHD or other types of disorders that seem to be present from birth on. Okay. So this is something to consider when if you have someone in your life or if you yourself have autism or ADHD, is how do you want to be viewed in this world? Is it a disorder or is it a way of being that should be accepted? So I just kind of wanted to bring this up because it is a movement. I think we will see a lot more out of this as the scientific community really starts to invest and investigate this idea, and gets away from kind of the clinical based aspects of autism. Okay. So I just wanted to bring this up at this moment so that we're aware of it. Now, now with that being said, what are some current hypotheses about what develops autism, and what really is the root kind of cause? And when I say cause, I don't mean was it a pterygium, was it the age of the parents or anything like that? I'm saying what drives the disorder, and there's been two hypotheses that have been kind of looked at to try and explain the cause of autism. And the first one is what's called the broken mirror hypothesis. Okay. And so we're going to get into a little bit of developmental psychology. I may have mentioned this in this class before, but what do I mean by the broken mirror hypothesis? Okay. The broken mirror hypothesis is from this unique ability that humans have around 24 to 36 weeks of development. Um, it's the ability to do what's called self-recognition, and then it's the ability to recognize that other people have an independent mind of their own. Okay. And so let me kind of rehearse what I mean by this. And I'm going to use two very simple examples to explain what I'm talking about in this developmental period, because these examples can often be used across species to test if other species have this thing that we're going to call theory of mind. Okay. So around 24 to 36 weeks of age, this is test one. There's like 16 of them. This is the simplest one. Is before a baby or a child is put to sleep, you put a mirror in front of them and have them interact with the mirror. And then you have them go to sleep. And then during that, while they're napping or sleeping, you put a odorless color dye on their forehead or on their nose. Okay. And when the child wakes up, you put the mirror in front of them again once they have their eyes open and active. And what you're looking for is if they've recognized that something has changed about them. Okay. And we find that around 24 to 36 months, the child will look in that mirror and they will reach and try to wipe or touch that colored dye on their head, trying to figure out what it is. Okay. I bring up this example. One is because it's one of the most simple one to explain self-recognition, that something has changed in me physically. There's something there that wasn't there before. The other reason this one is that we can use it across species, right? So of the species that we have tested, we don't find this self-recognition for like dogs and cats and most other species. We do find it for dolphins, elephants, other primates, and the like. Those who are more similar emotionally to human beings have this recognition ability. Okay, so this is one thing that develops during this period, this self-recognition. The other one is what is called recognizing, being able to take on other people's perspectives. Okay. And so I want you to use your imagination that this is two cups. And we have two children here, one and two. And in front of both the children, while they're there, the experimenter puts a ball into cup. Let's call this cup A, and we'll call this cup B. Okay. And then this kid number two leaves the room. Okay. He takes off. And then in front of the child number one, the experimenter takes the ball out of cup A and puts it in cup B. And then asks the child, when child two returns, what cup should he look into to find the ball? And around 24 to 36 months of development, the child correctly states cup A. Before then, children tend to say, well, no, they'll look in cup B because that's their experience. But around 24 to 36 months, the child comes to realize that the last time that child interacted with that cup was in cup A. And so they didn't experience the same thing I did. Okay. This is being able to take on the perspective of other people, to take on their reality. And this is what develops what is known as theory of mind, where we go and we think about what others think. So, for example, if we want a real life example, this is where a 24 to 36 month old a 24 to 36-month old, if they're happy and they see mom cry, they get kind of confused. They don't understand what's mom doing? She should be happy. Around 24 to 36 months, the child realizes they can be happy, but mom is sad, so they get curious. Why is mom sad? Why are you experiencing mom? Is everything okay, mom? And this is when that perspective starts to take place. On a biological level, this takes two mechanisms to develop. Okay. One, we have to have what's called a strong mirror neuroning system. Okay. Mirror neurons are when you are paying close attention to the individual sitting across from you. The neurons that are firing in their brain will start to fire in your brain, and your brains will start to mimic each other. Okay. And some examples of this include if you ever go to an action movie where there's a lot of movement with the action in the movie, if you're kind of bored with it, you can kind of sit, and if the actor leans left, the audience will kind of lean left. If there's a surprise, everyone gets surprised. Okay, because what we find is in research is the neurons that were firing in the actor's head when they did that action scene, if the audience is paying close enough attention, the neurons that were firing in that actor's brain will mimic and start firing the same neurons in the person who's watching the action scene. Okay. So that's one example. Another example is if you are ever get bored at a restaurant and you start to with whoever you're with, you kind of pick out who's here on a first date. Okay. And kind of and then you make bets on if you if you want to on who's going to have a second date. Okay. Well, the best way to predict that is to watch for what's called parroting behaviors. Because if two individuals are really liking each other and really into each other, their neurons in their brains will become synced together. And so at the beginning of the date, as you would say, they're probably sitting kind of different from each other. They might have their forks in different places and everything else. But by the end of the date, if they are looking at each other as if they were looking in a mirror and they look the same, and their drink cup, their fork, and their knife are in the same location. Their napkins are in the same location. They both reach for their drink at the same time and drink at the same time and then eat at the same time. You can pretty well bet with a large amount of certainty that there's going to be a second date because those two are so interested in each other, they become what's called neurally synced with each other, that their brains are actually more as one than two separate entities. So this is mirror neuroning. And again, we're all the amount of mirror neuroning we can do is dependent on people. Some people have a weak mirror neuroning system. Some have a really strong mirror neuroning system. We call these em empath empathics, or people who are very strong in empathy and feeling the emotions of other people. Okay, let's get back to our autism example. We find that about 70% of children with autism don't pass mirror neuroning or theory of mind tasks. Even the wiping of the uh, dye on their forehead, about 70% don't pass those tests, which has brought up the hypothesis that maybe they don't have that ability to neurally connect or connect on that mental level that allows for social interaction. Okay. The problem with the broken mirror hypothesis is is if it was truly a mirror neuroning issue or a theory of mind issue, we should see more than 70% of children with autism fail these tasks. So this doesn't quite explain completely autism, okay, and what drives autistic behaviors. The next one does a little bit better job. It's still being investigated, but it's seeing some pretty healthy outcomes. And that's the what's known as the overwhelming world hypothesis. And this one was explained to me by a colleague who specializes in autism. And he said, if you ever want to experience what a child with severe autism is going through, sit in a room with flashing lights. At each of the corners, at one corner, maybe you're blasting country music. At another corner, you're blasting hard rock. In another, maybe you're blasting rap. In another corner, you're blasting um, um, classical music, let's say. Lights are flashing everywhere. Your seat is very uncomfortable. Your clothes are really, really itchy. And he said, if you want to know the mind of an autistic child that has severe autism, that's what they're experiencing 24/7. And so what happens is you add that social layer of social interaction, and the world becomes so overwhelmed they have to retreat into those secondary rigid behaviors because they can't handle it. Basically, what this overwhelming world hypothesis suggests is that children with autism lack the ability to filter out sensory information that is not necessary for you to experience. So we talked about this during sensation and perceptions, how we actually filter out a lot of the noise in our world and we're able to focus on specific stimuli that we want to focus on, and it's like we don't even experience um, the other stimulus. What this hypothesis suggests is that autistic children tend not to have those filters that non autistic children have. Okay. So this one's building some evidence. There's been some neurological evidence that shows that area that is controls filtering stimuli, it tends to be weakened or non-existent. But we'll see where this one goes as far as an explanation of the symptomology. Again, as far as what causes it, what creates it, as you would say, we're not sure still. But we know it's not Tylenol. We know it's not vaccines. There seems to be other correlates such as parents' age and history of it in a family that seems to be some routes. But even as that video mentioned, the chromosomes that have been associated with some autistic children are also present in non-autistic children. So the root cause of autism is still well unknown. And this is also what's feeding into that neurodivergence. They're saying, well, there's not a cause of it. This is something natural. This is just a human variation of the human experience. And so it goes back to that neurodivergent argument. Okay. All right. So that's one example of a childhood disorder that in order to have a diagnosis, it does have to be diagnosed, or the symptoms at least need to have been present during childhood. The second childhood disorder is ADHD, or attention deficit hyperactivity disorder. Um, and we've already talked about last week why it's so prevalent and whatnot. And I'm going to skip the Japan example just so that we can kind of take a look at this disorder, since we already did the France comparison. So I'm going to, again, I think, play a video so that we kind of have a view of it, and then we will go from there.
What most people know, or think they know, about attention deficit disorder, or ADD, is that it's used to describe someone who can't stay focused, and when they really can't focus, they have attention deficit hyperactivity disorder, or ADHD. This continuum from one to the next isn't quite how it works, though. ADD and ADHD are actually synonymous, as in they're the same. ADD is an outdated term used prior to 1987, after which it evolved into ADHD to encompass more of the symptoms that people with ADHD often experience, which, in addition to being inattentive, includes both hyperactivity and impulsiveness. So somebody might be diagnosed with ADHD because they have symptoms related to not being able to pay attention, but they might also be diagnosed with ADHD if they have symptoms related to being overly active and impulsive. They might also have ADHD if they have symptoms of both. According to the Diagnostic and Statistical Manual for Mental Disorders, the 5th edition, the most recent update being in 2013, ADHD is split into 3 subtypes: inattentive, hyperactive impulsive, or both. Inattentive and hyperactive impulsive have a set of 9 symptoms each. For example, someone with the inattentive subtype might make careless mistakes, or not listen, or be easily distracted. And someone with a hyperactivity and impulsive subtype might fidget, or squirm around, or get up from their chair often. Now, you might be thinking that everyone fidgets now and then, right? Well, a diagnosis is given when someone has 6 of the 9 symptoms for either subtype for at least 6 months. Most commonly, though, children have symptoms of both subtypes, and therefore have the combined subtype. Since ADHD is considered a neurodevelopmental disorder, the symptoms also have to have started between age 6 and 12, and the behavior can't be appropriate for their age. Alright, but what causes someone to be hyperactive, or impulsive, or inattentive? Well, as you might guess, it's pretty complicated, and we don't really know. Probably a lot of different factors, and ultimately they all fall into some combination of environmental and genetic factors. One interesting clue to a genetic component of ADHD is looking at families. For example, a child with a sibling that's been diagnosed with ADHD is more likely to develop it themselves. Furthermore, if those siblings are identical twins, meaning they have the same DNA, their chances of developing ADHD is considerably higher. Having identical DNA doesn't mean that the twin is definitely going to develop ADHD, though, which again suggests that both genetic factors and environmental factors play a part. As to a specific gene, it's probably not one single gene that leads to ADHD, but rather multiple genes that determines how severe their symptoms are. These genes likely influence the production or regulation of the brain's neurotransmitters, which are signaling molecules in the brain that are released by one neuron and received by receptors of another neuron. This movement of a neurotransmitter from neuron A to neuron B is basically a message being relayed. It's like the neurons are talking. Dopamine is a specific neurotransmitter that gets released when the brain's involved with behaviors like getting a reward, taking a risk, and being impulsive. Norepinephrine is another neurotransmitter involved in attention and arousal. It's thought that lower amounts of these 2 neurotransmitters floating around contributes to symptoms of ADHD. The reason why these neurotransmitters might be down in the first place is still not well understood, and research remains ongoing. Now, treatment for ADHD can be tricky, since symptoms might vary from patient to patient, although it most often involves either behavioral psychotherapy, medication, or both. Behavioral psychotherapy is often targeted at children and focuses on teaching the child better time management and organizational skills. For example, having structured routines that they can follow, and then giving rewards when they stick to those routines. Also, involving both parents and teachers are important, and both behavioral parent training and behavioral classroom management have been shown to be helpful for children with ADHD. For adults, behavioral psychotherapy might focus on ways of decreasing distractions and also improving organizational skills. If medications are prescribed, typically the first-line options are stimulants. Since it's thought that low levels of neurotransmitters are involved in ADHD, stimulants are used because they tend to increase the number of neurotransmitters, like dopamine, between neurons, therefore reducing symptoms. Common and well-known ADHD medications are molecules that are chemically similar to illicit stimulants like methamphetamine, but there are some key differences to keep in mind here. All of these chemicals help to increase the release of dopamine from neuron A, but the ADHD medications typically cause a slow release of dopamine, whereas illicit stimulants like methamphetamine cause a really fast release of dopamine. In fact, it's this incredible surge of dopamine that disrupts normal communication between neurons and produces euphoria, and is the reason that illicit substances like methamphetamine are highly addictive. In contrast, the slow and controlled release of dopamine caused by ADHD medications is key and helps a lot of patients improve their focus and their attention. Thanks for watching. You can help support us by donating on Patreon or subscribing to our channel.
Okay, so that's a really good quick overview of ADHD and why, for example, stimulant medications are used over ones that you think would need to calm down the system, and kind of what the etiology of the disorder is. So I just kind of want to really quickly, to finish this up, emphasize some of the points that were made in that video. And so again, when we look at the diagnostic criteria, the individual mentions six or more of the symptoms with 6 months of some degree of impact. And again, I would just bring up the point, one of the issues with ADHD, and it can be brought up, is it needs to be present in multiple contexts, okay? If a child is displaying ADHD, for example, at school, but not church or not at home or not at the, I don't know, childcare or after school program, then it's that then that that hyperactivity has something to do with that school setting. Okay. And this is important to kind of keep in mind when you're looking at a child, or if you have a child who have symptomologies, is it occurring in multiple locations, not just one. Okay. Um, And the other note that you'll see here is symptomology is not what is called oppositional behavior or defiant behavior. Okay. ADHD symptoms don't necessarily have a defiance or an oppositional kind of character to them. And this is important because a child, for example, with oppositional defiant disorder, which is kind of the childhood version of conduct disorder that then becomes anti-personality disorder when the child is older, um, often has its root cause in things like attachment disorders, or the inability for a child to attach healthily to an adult figure early in childhood, and then to their peers in elementary school and up through high school. So we also need to kind of keep those kinds of things in mind as well. Okay. But often some of the symptomologies is a failure to give close attention to details, which makes kind of really careless mistakes, often difficulty sustaining attention on tasks or play activities that are appropriate for the child's age, often does not seem to listen, and often does not follow through with instructions, or failure to do schoolwork. Okay. And then the other ones, and again, you have to have six of all these together, often has difficulty organizing tasks, avoids, disliked, or is reluctant to engage in tasks required sustained mental effort, often loses things, and is often easily distracted by extraneous stimuli, things that are not really present or there for that environmental context, and is often forgetful of daily activities, such as doing chores, running errands, and those types of things. And so these are kind of the symptomologies. So this is the attention component. And then the hyperactivity component, again, and impulsivity, you need six more of these for about 6 months in multiple contexts. And it includes things like fidgeting, often leaving seats, running about and climbing situations, unable to play or engage in leisure activities quietly, always on the go, driven by a motor reaction. Excessive talking is often common, blurts out answers before questions are completed, um, difficulty waiting their turn, or interrupts or intrudes often. Okay. And so these are kind of the hyperactivity or impulsive components of ADHD. Okay. And again, the symptoms, because it is a considered a neural developmental disorder, the symptoms should be present before about the age of 12, in more than two or more settings, as I mentioned. And there's clear evidence that it's interfering with their quality of life, academics, and whatnot. And then some of the rule out disorders is the symptoms do not occur exclusively during course of schizophrenia or another psychotic disorder. One thing that you will note about individuals with psychotic disorders, including ones with different mood disorders, anxiety disorders, and especially things like substance intoxication or withdrawals, is they often will have symptoms of ADHD. So we have to be really careful and to rule out these different other types of disorders that might be driving similar symptoms that ADHD often has. All right. All right.